Thank you for joining us today as we discuss cannabis and epilepsy with Dr. Sandra Carrillo. Just a little bit about the Association of Cannabinoid Specialists. We have been ensuring the highest standards in the practice of cannabinoid medicine and safeguarding patient care with clinical best practices and interfacing with other stakeholders in the cannabis community since 2018. ACS is an international association of healthcare professionals on the forefront of cannabinoid medicine. Founded by cannabis physicians, ACS is uniquely positioned to advocate for the highest standards in the practice of cannabis medicine and safeguard patient care. We're also an advocacy organization striving to provide guidance to lawmakers and regulators at every level of cannabis control. ACS is also a membership organization. And professional membership is available to anyone, including doctors, nurses, pharmacists, policymakers, lawyers, those in the field of cannabis science, and more. Discounted memberships are available for recent graduates, as well as those living in Latin America and Africa, professors, and more. Student memberships are free for all full-time students and can be acquired by emailing info@cannaspecialist.org. I'll be putting that email in the chat as well for you in a little bit. Member benefits are available on our website, but they're also available here as well. We offer subscriptions to journals like Cannabis and Cannabinoid Research, clinical handbooks, video tutorials, and a well-stocked clinical reference library. 20% discounted pricing to our medical cannabis educational courses. That includes our new CME course, monthly networking events, and much more. As a reminder, ACS is a nonprofit organization. Events like this one support our mission as we work to educate and advocate for improvements in laws and policies that support patient access and the guided use of cannabis medicine. We hope you will consider donating to our mission so we can continue to bring you the expert panels like this one. You can visit our donation page at cannaspecialist.org/event_donation. I'll put that in the chat for you as well. Now I'd like to take a moment to introduce our speaker, Dr. Sandra Carrillo. Dr. Carrillo is a cannabinoid specialist, clinician, and co-founder of Medican Cannabis Clinics, co-founder and president of the Colombian Medical Cannabis Association, and former professor in charge of the scientific program of medicinal cannabis at the University of Panama. She is also the chair of the International Department of the Association of Cannabinoid Specialists and sits on the ACS Board of Directors. Is a review board member for the American Journal of Endocannabinoid Medicine and a scientific committee member of the Colombian Medicinal Cannabis Observatory. In addition to her medical degree, Dr. Carrillo holds a master's in health services management and is certified in anti-aging and regenerative medicine. Dr. Carrillo is an international speaker, a government policy advisor, an educator, and a volunteer. She is the co-founder of the Panama Food Bank and a volunteer at the Children's Epilepsy Foundation in Panama. Welcome, and thank you for joining us.
Thank you very much, Kelsey. I appreciate the invitation, and as part of the ACS, I am very excited to do continued education. I want to say thank you to Dr. Jordan Tischler, the president of ACS, because through all these years, he's been promoting education based on scientific evidence, which for all physicians and practitioners is the most important thing that we need in order to make the right decisions to prescribe for our patients. I'm going to share my screen. Now you're seeing my screen?
Yes.
Perfect. So today we're going to be talking about cannabis and epilepsy. This is a very important subject, and it was one of the first subjects that captured my attention when I started getting interested in cannabinoid medicine. The objectives that we're going to assess today in this presentation will be understand the physiologic basis for the use of cannabis in epilepsy, review the preclinical data suggesting the therapeutic potential of cannabinoids for the treatment of epilepsy, describe the anticonvulsant effects of phytocannabinoids, review the clinical data of cannabinoids as a treatment of for epilepsy, and understanding and discuss the benefits and adverse effect of the cannabinoid therapies. And for me, it's very important always to present, and we know that in every specialty, there is the specialists that they have the consensus and they make the statements about the latest treatments and where the evidence is. This is a report for the International League Against Epilepsy, where we see here the definition of epilepsy that is considered to be a disease of the brain defined by any of the following conditions. They report in here there should be at least 2 unprovoked or reflex seizures occurring more than 24 hours apart, 1 unprovoked or reflex seizure, and probability of further seizures similar to the general recurrency risk, at least 60% after 2 unprovoked seizures occurring over the next year, and the diagnosis of an epilepsy syndrome. Since we're going to be talking about refractory epilepsy, which is one of the main indications for cannabinoids, particularly CBD, cannabidiol, it's important to have a definition of drug-resistant epilepsy according to this publication in this official journal of the International League Against Epilepsy. Drug-resistant epilepsy might be defined as failure of adequate trials of 2 tolerated and appropriated chosen and used anti-epileptic drug schedules to achieve sustained seizure freedom. As many of you know, epilepsy poses a significant challenge in pediatric and adolescent populations. It's impacting not only seizures, but also psychological and cognitive comorbidities, leading to higher mortality rates than the general population. Drug refractory epilepsy, resistant to conventional treatments, affects a range of between 7 to 20% of pediatric patients. As you know, epilepsy has devastating effects on the lives of patients and their families, not only as direct result of clinical implications, but also due to socioeconomic consequences. The treatment of epilepsy is still very challenging, despite the introduction of several new anti-epileptic medications, and approximately 30% of patients are resistant to treatment. Epilepsy, as you know, is one of the most common neurological conditions affecting around 50 million people globally. When we talk about the physiopathology of epilepsy, it will be important to know that during the epileptogenic process, GABA activity decreases. The neurotransmitter GABA is responsible for the inhibition of the postsynaptic neuronal activity in homeostatic conditions. The presynaptic release of acetylcholine can be trigger of the dielectric phenomenon, being the glutamate, they're responsible for reinforcing and sustain the process. So we in here see the important role the GABA and glutamate have in the generation and the control of epilepsy. We're going to talk a little bit about the current state of the epilepsy treatment, and this publication in 2018, Chen et al. Posed this important question, and they were saying, has the overall prognosis of epilepsy improved after the introduction of more than a dozen new anti-epileptic drugs? And they did this study where they 1975 individuals who were newly treated for epilepsy between 1982 and 2012 were followed for 2 years minimum, and they found as results the 60% of these patients achieved seizure freedom. Of those, 5.5 with the first anti-epileptic medication, 11.6 with the second anti-epileptic drug, and 4.4% with the third anti-epileptic drug, and 2.121 with the subsequent anti-epileptic drug. This is showing us that when a patient is treated for the first time with the first medication, the results are good. But when the patient needs to take a second treatment and a third treatment, the probabilities of improvement are decreasing substantially. We know that there is many medications for epilepsy. We see in here all the different medications that they are available in the markets. But there is a big burden of the treatment of resistant epilepsy, because these patients, they have a very poor quality of life. They suffer the side effects of all these medications. They have cognitive decline. They have increase of risk of injuries, since many of these resistant epilepsies are very hard to control. So the numbers of seizures are very hard to reduce. There is a very restrictive lifestyle for the people that suffers from epilepsy. And of course, due to the hospitalization and all the implications that the use of multiple medications and the poor quality of life the patients have, increasing the healthcare cost and increased the mortality. It's been studied for many years, the anticonvulsant properties of cannabis. It's been known for centuries that cannabinoids or cannabis is being used as a therapy. We have as far descriptions in the ancient literature. The Arab al-Majusi described the anticonvulsant effect after nasal application of extracts from cannabis sativa leaves. The Persian doctor al-Badri in the century 15 before Christ described the efficacy of the treatment of seizures with cannabis. And definitely the anti-epileptic medications are the mainstay for the treatment of seizure disorders. However, 1/3 of the people, as I mentioned, 30% approximately, with epilepsy remain refractory to these medications. As you may know, cannabidiol CBD was recently approved as an anti-epileptic medication for 3 refractory epileptic syndromes in children and in adults. These syndromes are mainly diagnosed in children: Dravet, Lennox-Gastaut, and tuberous sclerosis. We are going to touch very little about the endocannabinoid system. We know it's a very complex system that all the humans and mammals we have, and is composed by receptors. I'm not going to stop too much in this. We have CB1 and CB2 receptors. We know CB1 receptors are widely distributed in the central nervous system and in other parts of the brain, of the body. And we have the CB2 receptors. They are very well represented in the immunological system, hematopoietic system, but we have many other receptors. We have also, as part of the endocannabinoid system, the endocannabinoids that our own body produce. And also we have enzymes that synthesize and degrade these endocannabinoids. It's important to always be very clear, knowing that the endocannabinoid system is responsible for important functions to keep the homeostasis in the body. Functions like appetite, sleeping, mood, and memory are very driven by the function of the endocannabinoid system. The CB1 receptor inhibits the release of neurotransmitters like glutamate and GABA that, as I mentioned at the beginning, are implicated strongly in the epileptogenic formation in the brain. The CB1 receptor plays a central role in the brain development and the synaptic plasticity, as we see in this graphic. We have distributed CB1 receptors in the cerebral cortex, in the prefrontal cortex, in the basal ganglia, in the hippocampus, and has a very important expression in areas related with cognition and mood, such as the cortex, hippocampus, and the amygdala. The endocannabinoid system is implicated in the regulation, duration, and frequency of the epileptic crisis due to the role of the endocannabinoids in the modulation of the neural excitability. As you see in here, we have the main regions where the brain have different sources of epileptogenic positive. The CB1 receptor presented in the hippocampus and cortex are explaining the effects of the cannabinoids on memory and learning, but also explain the anticonvulsant properties, because we will have different types of substances or medications that interact with this CB1 receptor. The antagonism of this CB1 receptor triggers epileptiform discharges in the electroencephalogram, causing the development of status epilepticus. And the activation of the presynaptic CB1 receptor can produce the detention of the epileptiform activity, demonstrating evidence of the anticonvulsant agonist anticonvulsant effect. And this suggests that the endocannabinoid system is tightly related to the potential mechanism of cannabinoids in the prevention of developing epileptic crisis or status epilepticus. It's important to know that if we have a dysfunction of the endocannabinoid system, that can lead to development of seizures. And we will find many mechanisms why these epileptic seizures can occur. And we see when they're doing evaluation of epileptic human brain tissue that is removed surgically and compared to healthy postmortem brain, they show numerous abnormalities in the epileptic hippocampal endocannabinoid system. They show downregulation on the CB1 receptor mRNA. They show reduction in the expression of the 2-AG synthesis, that we know 2-AG is one of the main endocannabinoids that our body produces. We see decrease of the CB1 receptor density. So the cerebrospinal fluid levels of anandamide in these studies that they did, they found the anandamide was reduced in patients with untreated, newly diagnosed temporal lobe epilepsy. So we see how important is the role of the endocannabinoid system in epilepsy. Now that we talk about the endocannabinoid system, we're going to talk about the role that the phytocannabinoids derived from the plant are having. We know that THC is a partial agonist of CB1 and CB2 receptors, but CBD has a numerous amount of interactions as agonist of the 5-HT1 receptor, agonist of the glycine receptors, modulator of the calcium channels, agonist of the TRBP. We're going to be seeing further how each interaction that we're seeing in here is crucial for the treatment of epilepsy in different patients. Cannabidiol is the second more prevalent phytocannabinoid after THC, and one of the main therapeutic potentials that we have find the strongest evidence to use it is in as a treatment in patients with refractory epilepsy as an anticonvulsant. One of the possible mechanisms of action, despite its low affinity of the CBD with the receptor CB1 and CB2, is the ability the CBD has to interfere in the activity of the enzyme fatty acid amide hydrolase, the FA, which is responsible for the degradation of anandamide, that is one of the important endocannabinoids that our body produces. There is very theories of the different receptor targets that we have in our body for CBD. CBD is a very complete, but it's a very complex molecule since it has many sites of activation. So it's important to know that CBD has different action as a modulator of intracellular calcium via GPR55 and receptor and the TRVP, that is the vanilloid receptor. Also, the CBD is being found to increase extracellular adenosine and inhibits its uptake, which helps to decrease seizures. Also, it's been found that the CBD could act as a possible positive allosteric modulation at GABA receptors. And also is an inhibitor of the anandamide uptake and has very important anti-inflammatory and neuroprotective effects. On another side, THC has the ability of stimulate and inhibit the secretion of neurotransmitter, but it has a psychoactive and psychotropic properties and is a partial agonist of the CB1 and CB2 receptors. Has demonstrated to present in different situations anticonvulsant effects, but some studies, few studies, however, can show that THC in certain doses could be a proconvulsant agent. So it's very important to be aware of this situation with THC. Now we're going to go to see what is the evidence that we have, the clinical, the in vitro, in vivo, preclinical and clinical evidence of the use of cannabinoids, and particularly we're going to be talking about cannabidiol or CBD. That is the molecule of the plant of cannabis that has more robust evidence. We know that as physicians, we have a hierarchy of evidence. We have systematic reviews and meta-analysis as a top and gold standard of the strongest evidence among with the randomized placebo-controlled trials. And we're going to see, for example, in here, the studies that they were done in vitro models. This is a publication of the Journal of Pharmacology and Experimental Therapeutics, where they show how the endogenous cannabinoid system regulates seizure frequency and duration in a model of temporal lobe epilepsy. This was a study that was done in 2003, and they showed that the expression of the receptor CB1 was significantly increased, 183%, in the regions of the epileptic hippocampus, demonstrated the role of the endocannabinoid system in regulating seizure activity. They also proven that the extended neuronal despolarization of an epileptiform discharge may cause a switch from suppression of GABA release to suppression of glutamate release. These are exciting and inhibitor neurotransmitter that play a fundamental role in epilepsy. This is another study in vitro where they were using WIN55, CB1 receptor agonists that show anticonvulsant effects against acquired epilepsy and status epileptic in primary low magnesium hippocampal neuronal cultures. So we see in here more in vitro evidence. In this other study, they were showing the different type of studies, preclinical and clinical, talking about the anticonvulsant effect, the proconvulsant effect, and the mix effect. We see in green where they were proving the cannabinoids or modulators of the endocannabinoid system. In green were the ones who showed better anticonvulsant effects. We see proconvulsant effects in some, but very little, just with the CB1 receptor antagonist is that they show more proconvulsant effect, but the majority of these studies show that they have anticonvulsant effects, as you see in the graphic in green. Epidiolex, as you're going to see, and you may know, is the medication that it was studied and created by GW Pharmaceuticals. Now it's called Jazz Pharmaceuticals, and they did also their studies and they published preclinical data. They showed the in vitro the effect of CBD on epileptiform local field potentials induced in rat hippocampal brain slices. They have also 5 animal model studies where they were showing with maximum electroshock or audiogenic seizures and PT set and pilocarpine and penicillin induced seizures. They show the therapeutic effect that it has, the Epidiolex or cannabidiol, and they proved that it was well tolerated and did not produce any motor deficit or neurotoxicity, proving the CBD significantly attenuated status epilepticus like epileptiform local field potential. There is many animal studies where they prove where besides cannabidiol, another molecules like CBDV and THCV show anticonvulsant properties in animal models. Right now in clinical studies, we don't have all this evidence yet, but the strongest evidence will be with cannabidiol, as I'm going to see. I'm going to be showing you. This is a very important review that they published in 2020 where they showed what are the pathologies. They have the strongest scientific evidence and studies that they were better done with the better samples of patients and with this statistic significance. And as you see in here, among the pathologies, we have epilepsy, but we have multiple sclerosis, chemotherapy related nausea and vomiting and other pathologies, but epilepsy is one of the pathologies that has a better and more robust scientific evidence. Now, when we're talking about the clinical studies or studies in humans, the use of cannabinoids, besides what I showed you that it was done in the century 15 before Christ, we have Professor Meshul and Carlini since 1978. They did the first study about treatment-resistant epilepsy with just 9 adults. And we see the other studies after this, and they were paving the road for all these new studies that they've been coming in the last 2 decades. This was one of the first trials that the Epidiolex did with the cannabidiol with 23 patients for refractory epilepsy and 9 patients with Dravet syndrome, where the results at 3 months, they show 39% of reduction, greater than 50%. And the adverse events were in 9% of the patients, and we're going to be seeing this, how this same situation is repeated in the next studies, but this was one of the earliest in 2014. Then we have this other studied in 2016. I'm doing it like in a chronological order to see how it's been advancing, and we're getting better patients and better design of the studies. In this study, it was a number of 74 patients, and they started with a CBD THC 20-to-1 ratio, starting with 1 to 20 milligrams per kilogram per day. And definitely, as you see in the slides, the improvement was very important. This is a publication, another publication of 2017, where they were talking about the current status of artisanal cannabis for the treatment of epilepsy in the United States. And it's very important, the numbers that we see in here. Let's remember that it was in 2017, but definitely they evaluated 272 patients from the Washington states and California, and they found that 14% cannabis was ineffective at reducing seizures, 18 experienced between 26 and 50% reduction, and 28 experience between 76 and 99, and 10% experience complete clinical response. Then we are going to see some of the studies that the Epidiolex did. As you know, Epidiolex is 99% pure CBD. Is in 2018, the FDA approved the use of Epidiolex or cannabidiol for the treatment of refractory epilepsy in patients with Lennox-Gastaut and Dravet. But later, in around 2020, they approved it for tuberous sclerosis. Epidiolex is a derivative from the plant, and in the presentation of 100 milligrams per milliliter. The Epidiolex is a great treatment, but it's challenging to use it because the costs are extremely high for the patients, but there is different countries that they cover for the patients, the treatment with Epidiolex. This publication of the New England Journal of Medicine was in 2017, and it was talking about the use of cannabidiol in patients with Dravet syndrome. As I mentioned, the strength of evidence is this was a double-blind placebo-controlled trial with 120 patients, and they were given a patient's doses of 20 milligrams per kilogram per day. And the results were the reduction of the seizures from 12.4 to 5.9 versus the placebo, that the reduction was 4.9 to 14.1. And the side effects reported in this study was diarrhea, vomiting, fatigue, somnolence, and in some patients, elevated liver transaminases. We're going to be talking about this because we're going to be seeing that now with more use of cannabidiol at high doses when it's in a purified form, we are going to be we need to be more careful in assessing the transaminases and other side effects and drug-drug interactions that they can appear. This was another study done by GW Pharma or Jazz Pharmaceuticals, another study, double-blind placebo control at 24 clinical sites. So it was multi-centric, 171 patients, again, for treating patients with Lennox-Gastaut, with a percentage of reduction in monthly drop seizures frequency from baseline was 43.9% in the CBD group and 29%. So we see the significance of the impact of the cannabidiol in these patients. And the patients reported side effects, but they were mild or moderate. Another publication about Lennox-Gastaut. This is a publication about the treatment of drug-resistant seizures published in the JAMA Neurology. This is from 2020, placebo randomized controlled trials. So I'm bringing you these studies because we see in here, talking about the hierarchy of the evidence, we have well done studies that they have statistically significance. And it was with these studies that they FDA approval was included and recommended to treat patients with tuberous sclerosis. And in these studies, they use doses of 25 milligrams per kilogram per day. And the primary endpoint of this study was the reduction in seizure frequency compared with the baseline of Epidiolex versus placebo. In this study, also the most common adverse events in these patients was diarrhea, elevations on transaminases, and decreased appetite, somnolence, and vomiting. The safety profile observed in this study was generally comparable to the observed in the prior studies. This was another study that it was done in Ljubljana, treating again patients with cannabidiol, and they found these patients had 21% seizure free. Another study that I showed you, Epidiolex, that is purified CBD, and this other study that it was done at the Sick Children's Hospital in Canada. They were using a preparation with CBD 100 milligrams per milliliter and THC 2 milligrams per milliliter, but in these studies, the amount of THC that were given to the patients per milligram per kilogram was 0.04, the starting dose. So we see that these studies, when they use the CBD dominant preparation, the amounts of THC are very small. This was a very interesting study where they were comparing the treatment of patients with CBD and clobazam, or CBD alone, or CBD plus clobazam, and they found the change in seizure frequency when the patient was using these medications, and they found 50% of reduction of seizures in this group, where the patients that were using CBD, 33% achieved the 50% of the reduction of seizures. When they were using CBD and clobazam, 44%, and when they were using clobazam only, 38%. So in conclusion, these preparations in the treatment of treatment-resistant epilepsy, they compare the efficacy of cannabidiol with clobazam, but we see in the graphic the CBD plus clobazam in conjunction gave the patients better results. This is another very important publication where they show a parallel between the use of CBD-rich cannabis extract over purified CBD in the treatment of resistant epilepsy. This is a observational data meta-analysis, and as we see in here graphic, the green dot are the studies that they were done with CBD-rich extract, and the gray dot is the studies that they were done with pure CBD or purified form, and the size of the circle is the number of patients. So one of the conclusions that they draw in this study was that the patients that they were using the CBD-rich extract, they have better control of the seizures at a less amount of milligrams per kilogram versus the patients that they were using the purified CBD, where they were using higher amounts of CBD, and at higher amounts, the patients were having more side effects. So this is an interesting study when they compare. There is many publications about cannabinoids, particularly CBD, in different forms and epilepsy. I'm not going to stop in each and every one of them. This was a publication that was interesting, published in 2020, where they talk about the pure CBD and enriched cannabis oil extract were found to be effective for controlled seizures. But it's very important that they want to stress the importance that drug formulations that they have to contain as low as THC as possible. And they are stressing the need that the products that they are available for the patients are not precisely well controlled. So we have a lot of mislabeling, and we find these children and the family of the patient accessing to preparations that they could be contaminated with heavy metals, with pesticides, or the concentrations of milligrams in CBD and THC, they are not properly labeled in the preparation. So they are having a lot of situations and side effects when the preparations that the patients are accessing, they don't have a control or proper standardization. It's important to know about CBD, and this is reported in the Epidiolex studies about the pharmacology. We know that cannabidiol is extensively metabolized by the cytochrome, mainly A4 and 2C19. And it's important to know that binds to protein more than 90%, and it could inhibit the CYP2C19 and 2C8 and 1A2, and the UGT1A9 and UGT2B7. That is very important, of course, and we always give the instruction to the patients that they have to take the medication after having a fatty meal or a food that contains fat in order to improve the absorption and the bioavailability. And it's well known that, and in these studies, I waited to talk to this. Now that we're talking about, we're going to talk about side effects. That is the last part of the conversation. That the high doses of cannabidiol in these studies of Epidiolex, they report that they can occur elevated liver transaminases in 8% of the patients taking 10 milligrams per kilogram, 16 taking 20 milligrams per kilogram, versus 3% in placebo. So of course it's dose related, and we have to be aware with these patients. So where we're giving to our patients high doses of cannabidiol, we need to assess the liver function. Also, in these studies, they found that 53% of the hypertransaminases were improved after the patient discontinued the CBD. So it's not like a permanent situation. And in some of these studies, they show that 40% were resolved despite continuing the treatment. So it's important as the doctors that we need to monitorize the patients. There is a lot of interactions, as I show you with the cannabidiol, because it has many targets in ion channels, different receptors, and it could produce a lot of drug interactions. And some of the most important drug interactions is with clobazam. We're going to see it in the next slides. But usually when we have patients with refractory epilepsy, they are coming with 2 or 3 medications, and among of these other medications, it's very common to see the patient taking clobazam, and we see that the patients taking clobazam, when they start taking cannabidiol, affects the metabolism of clobazam and increases the active metabolite of the clobazam, that is the N-desmethylclobazam, and that can cause for the patient side effects like somnolence and different potentiation of the clobazam. So in these cases, it's recommended, and we're seeing in the next slides, to reduce the doses of clobazam. But this always has to be I always believe in work in a multidisciplinary team. So always talking to the neurologist that has been treating this patient is very important, because we cannot come and just change or reduce the doses for a patient. It's important to share these decisions, of course, with the patient, but also with the neurologist. And also is very common the elevation of liver transaminases with the patients that are taking valproic acid. Is one of the main medications that produce this elevation of transaminases. So it's important to ask for patients when we're starting to treat them with high doses of cannabinoids, or particularly with CBD, a baseline of liver function the first day that they come, 3 months, 6 months, to evaluate the performance of this liver function. These are the adverse effects. They are occurring on 10% or more of the patients, and we found somnolence in 23 to 32 patients, diarrhea 23, fatigue, asthenia, decreased appetite, weight loss. Those are common side effects, but it's very, very hard that the patients have serious adverse events. Lately, and it's gaining a lot of attention, is the use of cannabidiol and hepatotoxicity. And this started because of the, that most of the publications using purified cannabidiol, they were using doses 25 milligrams per kilogram per day, which is a high doses for the patients. And in this study, is a meta-analysis that suggests the liver enzymes and the drug-induced liver impairment are common adverse drug reactions associated with cannabidiol used at moderate to high doses. And in this meta-analysis, they found the CBD hepatotoxicity was strongly associated with daily high dose of CBD and concomitant use of anti-epileptic drugs, particularly valproic acid. That's what we need to be not afraid when a patient is taking the valproic acid or the clobazam, but we need to be aware that there is this risk, so we need to be monitoring the patients. The clinicians are encouraged to actively inquire about CBD use and monitor for signs of elevated liver enzymes and liver dysfunction during CBD dose. At doses of less than 300 milligrams of CBD per day, the risk of liver impairment is likely low. This is also a recent publication. It's another meta-analysis, a systematic review about the liver impairment caused by the use of CBD. And they found in this meta-analysis and systematic review that a doses more than 20 milligrams per kilogram per day, the probability of develop this situation is higher. And also when they're using the patient's concomitant medications such as valproic acid and clobazam. So it's very important, as I said, to monitorize the patient with having a baseline of liver enzymes and monitorize the patients every 3 to 6 months. As we're talking about drug interactions, THC and CBD, as we mentioned, are metabolized by cytochrome P450, and drug levels can be increased or decreased by CBD and THC, not just CBD. Substances can alter the bioavailability of THC and CBD, and many drug interactions are theoretical, but we need to be mindful about these ones. There is a tool that I use in the clinical practice that is a drug interaction checker. It's a is available online, and you put the medication you're giving the patient and the name of the cannabinoid you're using, for example, cannabidiol. And if you put cannabidiol and clobazam, this drug-drug interaction checker shows you what are the possible interactions, because sometimes it's hard to memorize all these interactions. So we see in here how is affected the metabolism in the liver by the cannabinoids, and because they are primary metabolized in the liver. So it's important to remain aware of these drug-drug interactions. This is a publication that I found very interesting, because they were assessing the perspective on cannabinoids for treating epilepsy, and they see if they really do change the landscape after all these studies that they were doing. And they found that the antagonists of the cannabidiol, mainly mechanism of actions, are the antagonism CP R55 receptors, reducing calcium release from intracellular calcium stores and decreasing calcium levels, and potentially modulating neuroinflammation, that we know they are factors very important in epilepsy. They also cannabidiol desensitize TRVP1 channels, vanilloid receptors, reducing extracellular calcium influx and decreasing calcium levels. And also they found now they inhibit ENT1 adenosine reuptake pumps, because they are involved in the epileptogenesis, and they are increased the extracellular adenosine, so reducing the neuroexcitability. So definitely the cannabinoids are helping to reduce the burden that the refractory epilepsy is causing to the patients, but they are still another anti-epileptic medications, because these patients, they still suffer a lot. This is a systematic review published this year, where they were talking about the different type of studies that they were doing in the use of cannabidiol in refractory epilepsy, and it's been a lot of very good and solid in randomized placebo-controlled trials with the cannabidiol. And I want to finish with this, the position of the American Epilepsy Society on cannabis as treatment for patients with epileptic seizures. And the key points, they say that over 3 million Americans have epilepsy, and 1/3 have drug-resistant epilepsy seizures. And the anti-epileptic drugs support well-controlled studies for safe and effective treatments. They're talking particularly about the FDA-approved Epidiolex. They show efficacy for specific syndromes concerned. The American Epilepsy Society are very concerned about the over-the-counter medication or cannabinoids available in artisanal products, because, as you know, there is lack of quality control and standardization, potential for inaccurate labeling and harmful impurities, which we talked already, and unknown effectiveness and safety profile. So the recommendations that they give is support rigorous research on cannabis-based products for epilepsy. We already have the Epidiolex studies that, as I showed to you, they have good numbers. They have been multicentric, placebo, controlled, randomized studies, and definitely the specialist in epilepsy, the neurologist, the epileptologist, should be in the first line of the treatment. We have in the clinical practice, as with different specialties, a lot of consultations from patients that they are coming with refractory epilepsy, but always my recommendations is to bring to the picture the neurologist or the doctor that has been treating this patient for years. And in that way, we have a multidisciplinary approach, and by doing this, we can give to our patients a better and a more stable treatment. Definitely, as conclusions, CBD improves seizure control in vitro and in multiple chemical-induced and genetic mouse in vivo models in epilepsy, and also they perform safety profile studies, and we know that it has a promising safety profile if we keep the doses as we mentioned, because higher doses are more risk of side effects. Patient education is needed in terms of what we know and mainly what we don't know about safety and efficacy, and controlled human clinical trials are still required to better confirm the anti-epileptic properties of cannabinoids. We have actually long-term the long-term studies, 2 years, 5 years, but it will be interesting to see a 10-year long-term study, what are the results. So I want to thank you for listening to this conference, and I want to leave you with this phrase that I like: nothing in life should be feared, only understood. Now is the time to understand more, to fear less. Thank you to ACS for being this force, this academic organization that promotes education based in scientific evidence, because as physicians, as doctors, without this scientific evidence, we will not have that confidence into start prescribing for our patients. Thank you very much.
Great. Thank you so much, Dr. Carrillo. That was an amazing presentation. If we have any questions, now would be the time to ask them. Feel free to just go ahead and vocalize them or add them to the chat, and I can ask them for you.
So, doctor, I know you mentioned a bit of the issues being quality control and standardization. How do you think we can go about fixing these issues to create more accurate and valuable assessments?
Well, definitely it's depending on what country you are, because and almost in every country there is like what we call black market, gray market. But ideally, what we do, personally, what I do is I don't prescribe. The only products that I prescribe to my patients are products that I know they are regulated by the government, and they have in our country the permit from the Ministry of Health. But in countries like United States, I think they're doing like a big effort into do testing of the products, and there has been a lot of studies where they do random testing of the products that they're selling over the counter, and they found like almost 30 to 40% of these products that they sell over the counter, they have mislabeling, talking about the contamination, pesticides, heavy metals. In one study, they were finding that the claims in the label were that the product had just pure CBD, and they found that they were mixing CBD with benzodiazepines, or they said that the product has CBD and it has THC. I think these are efforts that as physicians we need to address with the patients, to advise them not to buy products. For example, the products need to have a COA. So in the COA, we can see what are the milligrams, and what are the cannabinoids, and what are the terpenes that the product has. So it's education to the patient, and as physicians, we have to get to know the products that we are recommending to the patients, because it's very hard and there is a lot of speculation out there, and the patients are buying what they think, and many times the patient comes to our consultation, bringing the bottle and saying, oh, I bought this online. What do you think? How much should I take? So it's very hard because if there are companies that we don't know, we can see the COA. It's at least the minimum thing that we can ask. But sometimes I've heard that there is some COAs that they are not even complying. They just put a sticker with a COA of some other product. So I think there's still a big challenge into regulate these products, but the main advice is to get to know what are the products that we're going to be recommending to our patients, and to tell the patient to make sure that at least this is a COA that is properly done, and there is reporting the important parts of the COA, such as like the concentrations of the cannabinoids, of the terpenes, and some of them, they have a report of the concentrations of heavy metals, or they show that they are not contaminated. So it's a huge effort. In other countries, we have products they are already regulated, but the sanitary by the government, the Ministry of Health. So we just recommend the patients those that they have that regulation and standardization. But it's complicated, and it's one of the biggest challenges. And this is, as you saw, the American Academy of Neurology and the League of Epilepsy Against Epilepsy, that is the number one concern that they have. They are okay, they are fine with the evidence that, for example, Epidiolex present, because we know it's a FDA-approved products, it's standardized and is reliable. But with these other hundreds of products that they're selling in gas stations, it's very hard to know.
Thank you. I guess I had one last question. Where can we find and connect with you, doctor?
Oh, I'm going to give my email in the chat. So feel free, if you have any questions, to contact me. I will put right now my email in the chat.
Thank you.
Thank you. Perfect. I think you're muted, Kelsey.
Thank you so much. So the next question is in the chat. It's, are you a proponent of the idea that a small amount of THC can assist with any therapeutic effect that CBD shows?
Could you repeat the question? Sorry.
Sure, no problem. Are you a proponent of the idea that a small amount of THC can assist with the therapeutic effect of CBD?
Can affect? The question is if a small amount of THC can affect the CBD?
Yeah. Can boost the therapeutic effect.
Oh, okay. Well, according to the studies and the publication when they are using CBD-rich extracts that, as we know, they have a small amount of THC. They claim that these patients, they need less amounts or a smaller doses, around, they say around 8 to 10 milligrams per kilogram, and versus the treatment with purified CBD, they were using in the studies of Epidiolex 25 milligrams per kilogram and even higher. So we are seeing in these studies and for all those patients that they're taking more than 300 milligrams or more than 20 milligrams per kilogram per day of CBD, they started seeing the side effects as I show of elevation of transaminases. So definitely there is two sides. There is one side that and I see this a lot in neurologists, that they prefer to treat the patients with the purified cannabidiol, because as I showed you, the evidence that we have with those studies are randomized placebo-controlled trials, are very well designed with good numbers, multicentric. With the CBD rich preparations, the studies are not like the same size of the ones that they were done by GW Pharma, but there is also evidence, as I showed you in the studies, that the use of CBD-rich products can benefit these patients with the small amounts of THC. Definitely, we have to be aware that if we're treating refractory epilepsy in children, we have to be extremely careful with the amount of THC that we use. That's what most of neurologists, when we're talking about refractory epilepsy, they prefer to use the purified form of CBD. But there is some cases where they use the CBD-rich extract, where a small amount of THC. And what the studies show is that the reduction of the doses is very significant. So we have to give smaller doses to the patients. And of course, for smaller doses is less side effects or adverse events. So it's just like two different approaches that and for both of the professionals can work. It's depending and how the professional is feeling more comfortable with, because as I said, the stronger evidence that we have is with the Epidiolex that is purified. But there is other studies that they have done with the CBD-rich extracts.
Thank you. Do we have any other questions tonight? All right, I'm going to go ahead and wrap it up then. Thank you so much, Dr. Carrillo, for joining us. It was an absolute pleasure to get to listen to you speak on such an important subject, and we appreciate you joining ACS.
Thank you so much for everybody, and I hope you have a good night. And if you have more questions, you can contact me on my email. Thank you.
Great, thank you, everyone.